Well, good afternoon or good morning if you're still in Central Time Zone, and welcome to this month's Lunch and Learn with the Center for Rural Migrant Health. It's a pleasure to have you here today. I'm looking forward to a wonderful presentation today by Dr. Casting. My name is Dr. Cody Mullen. I'm an Associate Director for the Center for Rural Migrant Health and a clinical professor in the Department of Public Health here at Purdue University. And we welcome you to our brown bag for the month. Our goal of these brown bags are to connect the university faculty and staff with community-based organizations for resources and collaboration opportunities around a variety of topics affecting rural migrant populations. This session is being recorded, and the link will be shared to the College of Health and Human Sciences YouTube channel. Will be included in the follow-up email as well as any approved slides, and that most likely will go out sometime next week. Our next brown bag is scheduled for May 13th, and we'll be talking about engaging youth in the public health space. Kathy Martin from Healthy Communities will be talking about their exciting youth engagement programs in Clinton County, and Dr. Yumari Ruiz, another associate director of our center, will be sharing her studies on youth resilience. But today's topic, hepatitis C in rural communities, will be presented by Dr. Monica Castings. Dr. Castings has bridged the IU Purdue divide in her educational endeavors, as well as she has attended both systems. The overarching theme of Dr. Castings' interdisciplinary research program centers on improving preventive health behaviors and care delivery. She seeks to understand health behaviors as they relate to cancer prevention and address barriers to engaging in those healthy behaviors. Dr. Castings has worked across the cancer continuum and has expertise in social epidemiology, behavioral oncology, and mixed methods research. So with that, we'll turn it over to Dr. Castings, and then I'll be back to facilitate the Q&A at the end of her presentation. Dr. Castings.
Thank you. Thank you for the introduction, Dr. Mullen, and thank you for having me. I'm going to start screen sharing. And Dr. Mullen, tell me if it didn't come through correctly.
Yep,
But
we are good.
perfect. I appreciate the time to be here. I want to start my presentation with a disclaimer that there is a lot of Hep C work going on in the state. It's happening across academic institutions, local public health departments. It is a vast network of people. So I don't want my talk today to come off as it's completely inclusive of everything going on. There's a lot going on that will likely not be touched on today, and there's amazing work going on across the state. But I am going to talk about some formative work I've done here and some ongoing efforts I'm involved in, just to give you a close-up look of some boots on the ground work. So our presentation today, I'm going to do a quick background on hepatitis C. I have a feeling most of the people on the call are at least generally aware of hepatitis C natural history and what the disease is, but just to make sure we're all on the same page, I'll give Indiana specific information and then talk about ongoing research projects I've been involved with, future directions, and leave some time for Q&A. So as a broad overview, hepatitis C is an RNA virus that's transmitted via blood-to-blood contact. It causes cirrhosis and liver cancer. It's the leading cause of chronic liver disease in the US, and there is currently no vaccine for hepatitis C. So we have one for Hep A and Hep B, and there's nothing yet for hepatitis C. So when we're trying to combat hepatitis C infection, where we start is with the prevention of infection through behavioral changes and then screening. Infection risk factors include getting a blood transfusion or organ transplant before 1992, when we started screening those universally, being on long-term dialysis, exposure to blood or infected needles, being co-infected with HIV, getting unregulated tattoos or body piercings, being born to a mother who has a hepatitis C infection, and sexual transmission is possible, but it is also very rare. So we're talking about the natural history of hepatitis C virus infection. If someone has an infection event, an accidental needle stick at work, a baby born to a Hep C infected mother, something along those lines, they have an acute Hep C infection, which can then go one of two pathways. About 25 to 35% resolve it spontaneously, and about 65 to 75% develop a chronic infection. And when that chronic infection happens, it leads to liver inflammation and eventually fibrosis of the liver, which can lead to, down the line, either liver cancer or liver failure. These processes are made worse or exacerbated by alcohol use, co-infection with HIV or Hep C. And then there are other pathways to get to liver failure or liver cancer that don't include hepatitis C. So that could be Hep A, Hep B, um, chronic alcohol use, other hepatotoxic drug use. So this is just one of the pathways to liver cancer and liver failure. And when we think about the disease progression timeline, when you have the exposure of blood-to-blood contact, that acute phase is often silent. The person has no symptoms, and it's 0 to 6 months. After 6 months, if they don't resolve it, that's a chronic infection, and that can last for years. Usually 10 to 20 years, 20 to 30 in some cases, where fibrosis is slowly happening. It's causing damage to the liver, but also doesn't have really obvious symptoms. So people can have this chronic infection and not know it. And then eventually down the line, several decades, is how you get to the end stage liver failure, or HCC is hepatocellular carcinoma or liver cancer, and it's fatal without treatment. Nationally, about 2.4 million people have chronic hepatitis C. Indiana's hepatitis C incidence is about double the national average. About 50 to 75% of people with hepatitis C are unaware of their infection status. And importantly and interestingly, 45% of people with hepatitis C report no risk factors for infection. So they will get this hep C diagnosis, but they don't report any intravenous drug use, no transfusions before 1992, no accidental needle sticks. They have no idea where they got it. And baby boomers, people born between 1945 and 1965, have 5 times the prevalence of hepatitis C infection compared to other birth cohorts. That younger birth cohort of like the 20 to 40-year-olds is seeing prevalence rise due mainly to the opioid epidemic. So we see more of a bimodal distribution with a peak down in that 20 to 30-year-old age range, and then a peak in the like 60-year-old age range. Indiana has among the highest per capita hepatitis C rates in the nation. There's a 129% increase in acute hep C since 2014. There were 5,000 confirmed and probable cases in 2021, and it is consistently in the top 10 for HCV incidence nationally. If we look at confirmed and probable cases of hep C, this includes acute, chronic, and perinatal transmission, so mother to baby transmission. You can see the rates over time. The peak looked like it was about in 2021, and since then we have seen a slowly gradual decrease in newly reported cases since then. When we're thinking about rural and urban disparities, there are higher numbers of hep C diagnosed in urban areas. It accounts for about 63% of newly reported cases, but because of different population distributions, it's actually a lower rate. So urban Indiana, the rate is about 46.6 per 100,000 population, and in rural Indiana, it's about 53.8. So the higher absolute counts, but lower per capita incidence in urban areas. So rural Indiana, some of the risk factors, there's a higher prevalence of people who inject drugs relative to the population size. There's limited access to testing, harm reduction services, and specialty care. There's higher percentages of poverty, unemployment, and social isolation. And then there are longer diagnostic delays. So frequently the diagnosis of hep C isn't detected until the person reaches the cirrhosis stage. And then there's a shortage of infectious disease and hepatology specialists in rural areas. Whereas in urban Indiana, there's higher access to federally qualified health centers, syringe service programs, and specialty infectious disease clinics. There's better telehealth infrastructure, so more broadband internet, better access to cell towers, which facilitates telehealth visits, and there's more Medicaid accepting hep C treatment providers in urban areas. So I just pulled up, I hope it's not too small on your screen, I pulled up this map from the Indiana, I think it's Department of Transportation, that would just highlight rural and urban boundaries in Indiana as we move on to the next step. So the blue areas in there are considered urban in Indiana. You can see There's Indianapolis here in the middle. This little blue dot would be Lafayette and West Lafayette. Up on the along the lake shore here, we have East Chicago and Gary, and then a little bit of a lull, and then we get to South Bend. And when we look at Hep C diagnosis in the state, you can see there are some blips in urban areas, but these dark areas, like along the eastern border here, are in an area that's mainly rural. You get this dark section here between South Bend and Gary, and then this dark section in southern Indiana that's mostly rural. And this is 2021 infection rates. In 2024, the good news is infection rates did go down, but you can see they're still highly centralized in the rural areas again. So this area here in rural southern and eastern Indiana, and then the non-metropolitan areas across the state. So when we're looking at rural versus urban disparities and just cases per 100,000 population, while of course there are diagnoses in urban areas, there are severe rural urban disparities with Hep C specifically. When we're trying to prevent Hep C infection, there has been a fun evolution of guidelines that is always keeping us on our toes. So in 1992, they started universally screening blood and organ donations. And then in 1998, 99, they started risk-based screening based off of a known exposure, intravenous drug use, a healthcare worker with an accidental needle stick, screening of a newborn if they knew the mother had hepatitis C. And then they realized there was that 45% of people with Hep C who reported no risk behaviors, and risk-based screening was missing them. And they also discovered that baby boomers had a really high prevalence. So they started in 2012 and 2013 one-time screening for all baby boomers, everyone born 1945 to 1965. And then in 2020, they just broadened that to include one-time screening for all adults ages 18 to 79 and all pregnant people with each pregnancy. So when we think about the recommended test sequence as it currently stands for hepatitis C, it's currently the screening test is a hepatitis C antibody test. So you'll get that. And if it's negative, it's considered non-reactive. You have no Hep C and you've never been infected with Hep C, and there's nothing else you need to do. If the antibody test is positive, that's a reactive test. It means you had hepatitis C at some point in your life, but we don't know if you're part of the 25% that spontaneously cleared it and you're fine, or if you're at the 75% who has a chronic infection. So then after the screening test, you need to undergo a diagnostic test, which is a Hep C RNA test. If that's negative, you're in that 25% who cleared it spontaneously. We don't really know why, but you're good to go as well. And if that's positive, that means you have a current hepatitis C infection and you need to be linked to specialty care for treatment. Hep C can be cured with treatment with direct-acting antivirals. When they first came out, probably about 15 years ago at this point, it was very expensive, but that cost is now down to a more manageable amount, especially with Medicaid expansion for treatment coverage. Access is increasing, particularly because they removed a restriction. They used to restrict treatment if you had fibrosis, but that's no longer a contraindication to treatment. So access is increasing and cost is decreasing. But because of the arduous screening process, there are significant disparities in Hep C screening and treatment. So people who either don't or can't access the healthcare system, people who don't have insurance, people experiencing homelessness, or people who inject drugs experience disparities in the Hep C screening and treatment process. Screening rates vary greatly by geographic region, patient age, insurance status, health system, and other demographic factors. So when we look at national data, national rates, Hep C screening across the country ranges from 1.7% to 70%. So it's a broad range based off of where you are, who you are, where you were born, and other factors. When we're looking at the state specifically, data pulled from IU Health and Eskenazi showed that their populations had about a 30% rate of people screened for Hep C, but I wanted to point out that this 30% is people accessing those health systems anyway. So we're likely missing the people outside of that health system or the people not accessing health systems at all. So now I'll move into looking at some of the work we've done across the state to improve hepatitis C screening and treatment. So when we started this work, what we knew at the beginning, based off of all the background information I've already given you, is that screening rates are very low. Certain groups are doing better than others, but really no group was doing well. And we know from this work and others on preventive health behaviors that provider recommendation is one of the strongest predictors of uptake of preventive services like screening. What we needed to learn was if screening guidelines were being implemented. So are providers aware of the guideline changes? Do they know that everyone 18 to 79 needs to be screened? Who are they recommending screening for and why? Are they recommending it and patients are just declining? And all of this is necessary to understand for future intervention efforts to improve screening and the hepatitis C continuum of care. So back in 2020, we did a survey that was funded by the IU Simon Cancer Center. It was a survey of Indiana clinicians. Every academic project needs a SASE acronym. So this one was HCV Spark, Hepatitis C Virus Survey of Providers' Attitudes, Recommendations, and Knowledge. We wanted to determine Hep C screening recommendation prevalence, characteristics, and barriers among a sample of primary care providers in Indiana, and identify what factors were associated with screening recommendation quality in this sample of primary care providers. And when we talk about quality in any healthcare setting, quality can be pretty hard to define. The way we defined it, just so you have a frame of reference going forward, we asked about recommendation strength, if they strongly recommended it to their patients, presentation, if they presented it as routine, optional, not discussed at all, how frequently they recommended it to their patients, and how timely. So if they recommended it at the current visit or if they said, you can do this just at some point, doesn't need to be today. And when we looked at it, we decided to split it up by high risk and average risk patients. So at this point in time, the recommendation came out that everyone should be screened regardless of risk. And we know that almost half of people with Hep C report no risk at all. But it looked like providers were still recommending based off risk. So they would give a strong recommendation to about 70% of their high risk patients and only 40% of patients that didn't disclose that they were, engaging in a behavioral risk factor that might put them at risk for Hep C infection. So sharing needles or something along those lines. Honestly, I think 70% for recommending for that population is very low and it should be up at 100%. Presentation, it was about 69% for high risk and 55% for average risk. For timeliness at that visit versus a future visit, it was about 75% for high risk and 55% for average risk. So it looked like providers were reporting that they would recommend it still based off of risk and not a universal screening for everyone. Other findings with this study, self-efficacy was associated with recommendations. So if a provider felt that they were able to identify patients who should be screened, able to discuss Hep C with patients and provide follow-up care in the event of a positive test, and able to refer patients for treatment, then they would have higher odds of recommending Hep C screening for their patients. Provider barriers were time and competing demands on their time. There's so much to discuss in a clinic visit. They don't have time to talk about everything, and this was something that would just fall off. Other barriers were access to referral services and comfort with disease management. If they didn't know what to do in the event of a positive, they did not want to screen a patient. Patient level barriers that were reported by providers were just knowledge and awareness, their interest in receiving the test, perceived stigma with the test, and treatment cost in the event of a positive, which, as I mentioned before, has gone down significantly since this time. So at the end of this, I have the list of what we knew going in. And what we now know is that providers are still recommending based on patient-reported risk behaviors, and barriers to screening are knowledge, time, and resources. Some of the questions of what we needed to learn. Are providers aware of guideline changes? Most of them seemed aware of guideline changes, but did not seem to be following the universal screening guidelines. Who are they recommending it for? Mostly high-risk patients. And are they recommending in patients are declining? Providers did report low patient knowledge and interest in getting screened. So all of these are necessary for future intervention efforts. So from there, we took what we learned from providers about what they needed to improve hepatitis C screening, and we developed an educational intervention. So we developed a multi-level intervention aimed at both patients and providers to increase hepatitis C screening rates, specifically in the baby boomer cohort, and determine intervention feasibility, acceptability, and usability in the primary care setting. So this was specific in the baby boomer cohort. I want to point out, here's our screening guidelines, and this was right here. So this was funded right after screening changed to one time for all adults, regardless of age. When we wrote it, screening guidelines were just for baby boomers, and then by the time the grant was funded, it was for everyone. And we had extensive discussions with our team. And because an 18-year-old and a 79-year-old likely had vastly different preferences and needs as far as education, we decided to just focus on the group that has been recommended to get screened longer and still did not have high screening rates. And then hopefully in the future, we were planning to adapt it for other age groups based off of what we found. So we just focused on the baby boomer population for this specific study. So phase one was multi-level intervention development. We started by developing a prototype based on the literature and previous work by the team. And then we had a community advisory board that provided feedback on the patient level intervention and a provider advisory board that provided feedback on the provider level intervention. And then we moved on to phase two, which was interviews with patients and providers, where they looked at the intervention, walked us through it, and gave us feedback on intervention feasibility, acceptability, and usability. So the patient level prototype consisted of a reminder letter that was mailed to the patient's home before an upcoming visit that included information about their appointment and let them know they were due for screening. Within that envelope, we also had a CDC informational pamphlet. And then once they got to the clinic, we had an in-clinic educational video that they could watch while they were waiting in the provider's office. Then the provider level prototype started with a 30-minute educational session intended to be delivered in a format like this during a lunch and learn, and monthly performance feedback emails, which would include their screening rate for their eligible patients and their overall clinic screening rate. Our community advisory board, we worked with community outreach and engagement at the IU Cancer Center to recruit members of the community. There were 4 members, all born between 1945 and 1965. 3 of the 4 were female, 2 were Black, 1 was white, and 1 was Hispanic. We met 3 times for 2 hours over a 3-month period, and provided feedback on the intervention design, content, messages, graphics, all of their preferences. Overall, for our prototype, they liked the content and methods of delivery. They requested much more information than I originally included on why baby boomers are at a high risk of infection. They indicated they wouldn't want to watch this in the waiting room, even if they had headphones, because they were concerned that other patients would wonder if they were being targeted and it would be stigmatizing. So we shifted the study around so that they would get it once they got back to the exam room. They provided valuable feedback on visuals, valuable feedback on audio. One of the pieces of feedback they gave is that I talk way too fast and I needed to slow down. And then they provided other specific feedback. So the CDC pamphlet that we included, this is a very small graphic of it. It would be about as long as a regular sheet of printer paper. But this blue color, they said, was really hard to read. And the problem with this being a CDC developed pamphlet was that we were not allowed to change things on it. We could either use it or not. And so we had to have conversations of like, is this so hard to read that you wouldn't want to see it at all? And they said if it was this or nothing, they would take this, but they would have preferred instead of blue, it's just black and white. So it would be much easier to read. They also had information like this. So this was a graphic we originally had on our educational session. It was just filling white space. It was not intended to provide any content at all. But one of the community advisory board members said, I didn't even listen to what you were saying on this part because I just kept thinking that's not realistic. There's no way I could jump that high. So we just shifted it to another picture to fill white space that would be less distracting to the listener. And then on an informational slide about Hep C transmission, this graphic was used to illustrate one mode of transmission was needle sharing, but a community advisory member commented that they thought it looked like a black hand giving the needle to a white hand and it was stigmatizing. So we just changed the graphic to just be a general, it was like we just need to show a needle really. So we changed it to just a general needle picture. For providers, we recruited them through professional contacts of the study team. We had two primary care providers and two gastroenterologists. Three of the four members were female. One was Black, one was Hispanic, and two were white. Each member participated in 3 meetings over 5 months. So not every member was present at every meeting, but every meeting had at least 2 provider members. They gave us feedback on all of the content for the provider level of intervention, and then one of our providers did review the content for the patient level intervention just to ensure that the content was accurate. Overall, they liked the content and delivery. They told me that 30 minutes for an educational session was way too long. They didn't mind performance feedback emails, but reported that they do receive a lot of them, which I was not aware of, and thought it might be less likely to get ignored if it was actually printed out and left in their mailboxes as opposed to email. And then they wanted a lot more information on the role of a primary care provider in the screening process versus what a gastroenterologist would do in the event of a positive. They asked for added content on any contraindications for treatment. So there was a change around this time that currently using alcohol was no longer a contraindication and those patients should still be screened. They asked for clarification on risk factors. So a lot of them were under the impression that being monogamous didn't put the patient at risk for Hep C infection. So we added a lot more information about how Hep C can be sexually transmitted, but that's actually not the main way it is transmitted. They stated providers would be more likely to be interested in the topic if the title of the talk was something that reflected it would be a way for them to help their patients. And they asked us to list barriers and then provide resources to address those specific barriers. So tangible ways to address both patient and provider barriers. And based off this feedback, we developed this one pager, which was places that patients could go to get low or no cost Hep C screening in the event they don't have insurance. I will say that this information at this point is fairly old. So if it is no longer accurate, don't like screenshot this and try and use it because I need to update the content. This is what we gave providers originally in about 2022 when we were doing this at the beginning. But we have locations that they could get low cost or no cost Hep C. Other important notes, so if it was along an Indigo bus route, other things offered at that location, the address, and then the website where it could be accessed. Once we had the intervention developed, we moved on to phase 2, which was usability. So we did interviews with 8 patients and 7 providers. We recruited the patients through the Indiana Clinical and Translational Sciences Institute and providers also through the Indiana Clinical and Translational Sciences Institute, but someone at the CTSI emailed providers directly so that they would know that it wasn't just a spam email that got it ignored. And then patients reviewed the patient level intervention and providers only reviewed the provider level. Overall, patients had a very positive response to the intervention. One of them said, before I talked with you, I was much more frightened of the word Hep C. They showed appreciation for how much they learned. All of them indicated they felt prepared to talk to their doctor about Hep C. One note we made was that there was a sentence in the reminder letter that said 3 out of 4 people infected with hepatitis C were born between 1945 and 1965. And most of the participants incorrectly interpreted this as 3 out of 4 baby boomers are infected with hepatitis C. So after this, we changed the wording on there to be that 1 out of 30 baby boomers are infected with hepatitis C to remove that level of confusion. Providers noted this would facilitate conversations with patients, especially given limited time during a patient visit. One of them said, but I've got 15 minutes. There's no way I'll ever get down to that history or have the time. So it's like, oh, for God's sakes, just let me screen you for Hep C. Contrary to current guidelines, many providers stated they assessed risk of Hep C infection by asking the patient about their sexual history. And most were aware that guidelines were for all people, but fewer were aware that it's also recommended for all pregnant people with each pregnancy. So this was published in the Journal of Cancer Education. It ended with the patient level intervention, which was the reminder and the informational letter, the CDC pamphlet, and what ended up being a 7-minute video that they could watch in the clinic. The provider intervention, the 30-minute educational session was cut down to 15, and then monthly performance feedback was switched from email to paper in their mailboxes at work. So all of the work that I've described to this point is talking about getting people right here at the beginning for the Hep C antibody test, so that you know either if they've never had it or if it's reactive and they need a diagnostic test. But what if we could take all of that away and only start with a point of care RNA test? That would be ideal. It would cut down a tremendous amount of work and really facilitate the screening cascade by cutting out multiple points where people tend to drop out of care. So I have worked with a colleague in the School of Biomedical Engineering, Dr. Jackie Lennis. She has developed point of care diagnostic tests for HIV and HPV, along with Dr. Natalia Rodriguez, who is in my department, and received a grant to develop an HIV diagnostic platform, and then got additional money from NIH to adapt that to also work for Hep C. The technology used for HIV can be easily modified for Hep C detection in her platform. So she has developed and patented multiple sample to answer diagnostic tests that have similar sensitivity to the longer lab-based test without extensive equipment. It's handheld and uses cell phone USB as a power source. So we worked with her. We'll work with community-based organizations, clinicians, and patients to understand their needs and desires to design a test that's feasible and acceptable to target audiences. That's my role in this project. Dr. Linus is taking the feedback that I get from community members and clinicians and using that in the development of hepatitis C screening assay. And then finally, we're working with Dr. Lauren Nephew, who's a transplant hepatologist at IU Health, to evaluate the efficacy of the device. So as we're going through all of this, we have been working up here in acute Hep C infection with screening or identifying chronic Hep C infection through either getting patients to get screened for antibody testing or developing an RNA test so that they can skip straight to that diagnostic testing. But we also want to think about patients all along the cancer continuum of care. And if we miss them at the acute phase and we miss them again at the chronic phase and they keep going and going, they're eventually going to end up down here in the cirrhosis, liver cancer, liver failure phase of the disease progression. And there are also significant disparities along this disease progression, which I have worked with Dr. Lauren Nephew at IU Health on a project called Liver Transplant Community Access for Referral Equity. And the snappy acronym for this project is LT CARE. So when we're thinking about liver cancer and disparities, the only life-saving treatment once the patient progresses through and is at the liver cirrhosis phase is liver transplant. Without transplant, the median survival for someone with decompensated cirrhosis is about 2 years, and IU Health is the only liver transplant center in Indiana. So this results in significant disparities. Many populations experiencing disparities receive healthcare in safety net hospitals and community gastroenterology practices. And within these practices, providers lack access to transplant hepatologists. Compounding these issues are factors such as provider time constraints, potential biases, navigational challenges in the health system, varying levels of patient literacy and social needs, And then there's variability among community GI practices, which is influenced by factors like like size, either small or large practices, and location with rural versus urban. So if the only transplant center in Indiana is IU Health, someone in a rural area would not have easy access to get there. And sometimes they're driving, more than 3 hours to get to Indianapolis for this care. There is currently no intervention addressing equitable access to liver transplantation for the people along the Hep C continuum of care who get to that point and need it. So for this project, the first aim was to engage patients and providers to develop the intervention. And then phase two is implementing the intervention in GI practices to evaluate implementation outcomes. So the goal is to identify patients, usually in rural areas in an underserved area, that needs to be referred for liver transplant and facilitate that process. So we have completed aim one of this project and we are currently in aim two. Aim two is 12 months of implementing it in liver clinics in the community. And we targeted practices with larger numbers of racial and ethnic minority patients, rural areas within counties that are in the bottom quartile of waitlisting to death ratios. So that's a transplant measure to see how many people are on the wait list and are not getting a transplant but before they end up dying from the disease. So the intervention components that we developed with patients and providers, we have this fancy graphic. The patient level intervention was a patient education, which I'm going to show you an example of in a minute. Provider level LT check was a clinical decision support tool that helped a provider figure out which patients needed to be referred for liver transplant, audit and feedback reports, an education session, and then offered teleconsults for people who can't make it to in-person visits. This is an example of part of the patient education. There were multiple components to the patient education, but this is just one of them. So it's a cirrhosis health tracker and it's a checklist of various aspects of cirrhosis. So something like hepatic encephalopathy. If someone has no confusion or it's managed with medication, or if someone has confusion leading to more hospitalizations or emergency visits, various levels of jaundice and their functional status, to help the patient understand maybe if they need a referral for liver transplant or not and facilitate the conversation with their provider. So this is just part of the LT care intervention that we're implementing to get people that are down the line in the liver cancer continuum of care and get them into treatment more effectively, particularly if they're in a rural area with less access to care. So of all of this work, overall takeaways from this work, Hep C screening is an important public health tool. Despite advances and recommendations, screening rates are still low. And because of the current screening process, there are significant disparities in people who don't or can't regularly access healthcare, people without insurance or experiencing homelessness, and people traditionally disenfranchised by the healthcare system. Key steps to improving the continuum of care include reducing barriers to screening, improving knowledge and awareness and simplifying the testing process, reducing health disparities by improving access to care, or developing point of care tests that can be implemented in the community, and improving linkage to care either for Hep C treatment itself or down the line with liver transplant services. I do want to acknowledge my collaborators, including members of the Community and Provider Advisory Boards and my community partners, including IU Health Positive Link and the ZIP Coalition, the Zero is Possible Coalition, and various funding mechanisms that have supported this work throughout the years. And with that, I am happy to take any questions or comments at this time.
Thank you for that great presentation. Yeah, questions or comments from anyone? And I do have the chat open if you prefer to type it, and I'm happy to read it out loud as well.
I'll jump in. So thank you, Monica, for that. Sorry, my light had to go off at the inopportune time. The newspapers and stuff are reporting that the governor is not going to sign the syringe program, but he's just going to let it go through without signing within it, which is still a win,
Okay.
in a way within it. But thinking of your work, especially with older adults and others, is what might be next steps, or as we're thinking about the opioid and methamphetamine epidemic, how do we also increase screening for some of those populations that are most risk when we have a kind of a very still more reaction approach to how we do prevention too.
As I was earlier this week, as I was finalizing the presentation, I pulled up the legislation and I was like, it's still sitting on the governor's desk. Why, it's been a while now. Why hasn't he signed it yet? So for those in the group that might not be keeping an eye on syringe service program legislation in the state, the needle exchange program was going to end this year. They did extend it, which honestly I didn't know was going to happen, with some changes. I believe now it's a one-to-one exchange, right, Dr. Hubach? Is it? No, do I have that wrong?
I need to confirm on that.
It
I was
might.
hoping that didn't make it in, but I will double check.
Someone added that. It might have gotten kicked out at some point. Um, and the original was to approve it for 10 more years. I think that was cut down to 5. But it did get through the Indiana legislature, both the House and the Senate, and was sent to the governor's desk. I guess he is not signing it, but he's also not vetoing it, from what I can see. So it will just go through. It's like an I don't like this, but it's going. So when we talk about hard to reach populations, especially in this group, reaching needle exchange and syringe services programs are a great way to reach this population. And if they aren't happening, we frequently don't see people in this population. It's also because I don't do a ton of work with needle exchange programs, I don't ever want to jeopardize the work they do. So I hesitate to like jump in and be like, when your people come in, can I talk to them more? And they're like, no, just like let them come in and go and don't jeopardize it. So the fact that it seems to be going through makes me hopeful. And anything we can do to reduce stigma in this population will improve Hep C screening. And we have seen, particularly after the outbreak in Scott County in 2015, that these work. It was actually a really big public health win that we got that under control using needle exchange. So I don't think I have a good answer for you, Dr. Hubach, but any policy I see that can reduce stigma around this tends to be a win because it's a group that is so highly stigmatized and they're so hard to reach because of that, that anything that can make it easier is beneficial.
Thanks.
I know the initial legislation when introduced in January was 2 lines, and I think we're now up to 7 or 8 pages is what passed. So I'm sure there's a lot more nuance to what the initial date of just adding 10 years. We do have a question in the chat, so I will read this. Apologies if I missed this. How would the providers delivering Hep C education screening be given the provider training? And are you targeting docs within specific types of healthcare organizations, for example, private PCP/GI offices or FQHCs, health departments, other healthcare social service organizations?
Hi, Catherine. So that's different across the projects that I talked about. So the educational intervention that I led, the providers were given provider training at like a separate lunch and learn that was just me and the providers, or another primary care provider and me talking to providers. And then the education for the patients in their clinics were given to the clinic itself for the patients to get at the visit in the hopes that the patients came into the encounter with the physician already knowing the information to save the physician time. So the goal for that project wasn't to like do provider communication training so that they could talk to the patient. It was actually like, you don't have to talk to the patients. We will give that education beforehand and save time since time was one of the biggest barriers for them. For the liver cancer project, those providers attended like a separate outside training, either virtual or in person, usually in the evenings. Um, that was an onboarding for the project and education on the liver transplant for that particular clinic. And then we targeted community GI practices for them. And for the Hep C educational session, we targeted primary care clinics for those. So it was different based off of which project I was talking about. But for both of them, because provider time is so short, instead of doing provider communication, which is like where the heart of all of my work in HPV and vaccination lies, we actually tried to take away some of the need for provider education because they just said they didn't have time.
Thank you. Any other questions? Well, if not, thank you, Dr. Casting. Apologize for saying your name wrong earlier. I was
No.
reminded, but thank you for a wonderful presentation. And second time I've seen parts of it and starting to sink in a little bit. So thank you for that. Thank you all. We'll be sharing out the recording probably early next week, or maybe even the week after. I forget. Next week is spring break as it's getting freezing and snow's coming back. But we'll be sharing that out shortly. And then a reminder that our next session will be May 13th, which will be a discussion with Kathy Martin from Healthy Communities and Dr. Yumari Ruiz, looking at engaging youth in the public health space. So looking forward to seeing you all on May 13th. Thank you again, Dr. Casting. Have a wonderful day.
Thank you. I also want to give out a shout out. I saw Emily is in the audience, one of my community partners from Positive Link. Hi, Emily.
Hi, Monica. Good
Good
to
to
see
see
you.
you. You too.
Great.
Take care, everyone.